So good afternoon, everybody. Thank you for coming to the University of Colorado Cancer Center Grand Round Series. I'm very honored to introduce our speaker today, Dr. Neerja Chatla, who is from the All India Institute of Medical Sciences in New Delhi. And I had the distinct privilege of speaking there back in November, and I want to talk a little bit about AIMS before I introduce Dr. Chatla, just so everybody has some kind of idea of how things are done in India, as well as kind of how lucky we are to have a speaker from an institute such as AIMS. So the All India Institute of Medical Sciences is one of the oldest medical schools in India. It's based in New Delhi. And every year, and Neerja can correct me if I'm wrong, almost 150,000 people take the examination to be admitted to AIMS. It's the premier medical school in India, and only about 100 of them get in. So that's a 0.01% rate of acceptance. So we're talking about a school that's really attracting the best minds in medicine in a country of about 1.3 billion people. So we're extremely honored to have Dr. Chatla here to speak to us. Neerja Chatla is a professor of obstetrics and gynecology as well as epidemiology at the All India Institute in New Delhi. She is an internationally renowned speaker on HPV-related diseases and gynecologic cancer and has run several large international trials in HPV-related cancers, including cervical cancer. Dr. Chatla is also currently the chair of the FIGO Cancer Committee, and FIGO stands for Fédération Internationale d'Obstétrique et Gynecologie. That's the French name for the International Federation of OBGYN, which is the largest group of groups of organizations that represents organizations in OBGYN across the world. So constituent members are the American College of OBGYN, the Royal College of Obstetrics and Gynecology from Canada and the UK. So she chairs the Cancer Committee for that very large organization. So we are very honored to have her here to speak to us. She was giving a talk in New Orleans at the Society of Gynecologic Oncology meeting and was gracious enough to travel to Denver to talk to us and to our cancer center about HPV screening in India. Screening for cervical cancer in a country that has 200,000 cases of cervical cancer. And while we've made great strides in the U.S. and the Western world, the burden of cervical cancer pathology is still quite large in the developing world. So, Dr. Chatla, thank you.
Thank you, Saket, for that very kind introduction. Good afternoon to all the distinguished faculty and residents and all the staff who are here. And it's a real privilege for me to visit Denver. I thank the university for the kind hospitality as well. And the talk which I was asked to give on cervical cancer screening and HPV control in India is such a large and diverse topic, and there's so much that one can talk about it. But I selected some portions of it, and if there's something you feel wasn't answered, I'll be only too happy to stop and talk to that. I can use this for the pointer. Yeah. So Saket said so much about AIMS, but I also want to say that the building that you're seeing is actually one part of it. We are located on the 3rd floor. Anybody visiting New Delhi is welcome to come and visit us. But we have several satellite centers as well. And all told, we have about 2,200 beds. And on a daily basis, we have about 14 to 15,000 patients on an everyday basis in the various outpatients and special clinics that we run. So yeah, so this is a very clean view of it and not with the crowded patient load that you would see on a typical day. So I thought we could talk today about the cervical cancer burden and HPV epidemiology in India, about the various screening methods, what works, what doesn't. We have some new resource-based screening recommendations for the first time from the Indian Federation, which is an affiliate of FIGO, and about HPV vaccination. So all of you who are familiar with oncology know about the kind of maps that GloboCan turns out. And time after time, India continues to be in the orange, which is like the second worst in terms of incidence rates, not quite as bad as some of sub-Saharan Africa and some of Latin America. For the first time last year, there was a bit of encouragement. We were still dealing with almost a fourth of the world's burden, but the numbers for the first time were a little bit less, from 132 down to 122. If you were to translate this map into the proportion of disease, this is what India would look like. It would just bloat up and the US would almost disappear, and so would Australia. And that's what happens to this world mapper. If you go to look at it, India bloats up for all the wrong reasons, be it anemia, tuberculosis, illiteracy, and so on. So that's the sort of situation we are in, despite the little bit of decline. So what has now happened is that breast cancer is the commonest cancer and cervix is the close second. However, if we look at the age standardized incidence rates, we see it's not just a function of our numbers, it is also the fact that we are now the highest amongst all the neighboring countries, because some smaller countries like Bangladesh and Nepal have managed to get some sort of program going to some extent. So this is a disquieting thing, despite the downward trend and despite the slightly decreased numbers. Again, if we look at the age-specific ASIRs, we see that there is a high proportion of women in much younger years of life than you would see for ovarian or breast, and the years of life lost to cervical cancer are more than for any other cancer. I would also like you to note here that there are reasonably fewer numbers under the age of 30 with the disease. And so you will see that we talk about screening beginning at 30 because there's a large proportion above that which we first want to capture. So our really first endeavors were to look at the HPV type distribution in cervical cancers. There had been sporadic efforts to do the typing by PCRs, but this was the first time that there were two centers, the Cancer Institute in Chennai and us in Delhi, who used the reverse line blot assay, which later became the linear array, to look for 37 different types and see what were the proportions that were seen. And of course, 16 and 18 were the commonest. We then did a meta-analysis. The meta-analysis was originally started out as a meta-analysis for South Asia, but we found that there were only publications from India that fulfilled the criteria of a meta-analysis. And we could see from this that 94.6% of the cervical cancers were positive. Now, if you go to wall boomers, you see 99.7, and it is widely agreed that this is the cancer which has the highest attributable fraction to an infectious agent. So it all depends really on which method you use, what are the primers, and so on. And having said that, 95 is a substantially high number anyway. And then you have 86.5% for the HSIL and proportionately, but if you see the numbers, they are much smaller, and that is because there is no screening. You would normally expect this number to be smaller than the numbers of pre-invasive, but because there is no regular screening, these numbers are only coming out of some small studies. And further, we could see the distribution of 16 and 18 for squamous cell carcinomas and adeno, and it was still 16, which was commonest even for adeno, although the proportion was much smaller. And you see that these numbers are way ahead of the 70% that are reported for 16 and 18 globally, and we found a higher proportion of 16, 18 in cancers as well as in the precancers that have been reported from global data. And this, when put together by the WHO's ICO, which is the HPV database, has found that cervical cancer in India caused by 16-18 is 84.1%. This is actually very encouraging news for the use of the current vaccines, where we expect then that the efficacy should be even better than has been reported in the world literature so far. So coming to screening, and who is better known than George Papanicolaou and the impact that he made on the lives of hundreds of thousands of women, bringing about a decline of 70% by the use of the Pap test. And yet, it is widely agreed that if this test went to FDA today, it would not get licensed because the sensitivity in a meta-analysis of studies from North America and Europe found that it was just around 55-60% sensitivity that it had. So how was this test so successful? Not because it had a great sensitivity, which is actually a requirement of all screening tests, but because it was done repetitively, year after year in America, every 3 years in the UK, every 5 years in the Netherlands, and still enough to get the women at some point in the long pre-invasive phase of about 10 to 15 years before they progress to invasive cancer. And even if they should have, they would be treated at a time when it would not impact mortality. So that was the success story of the PAP. And they say that he was nominated for the Nobel, but at that time they did not give it to two people together, so he lost out. And then they didn't give it posthumously, and he lost out again. So the Nobel came for the first time to Zurhausen, who went against current dogma and postulated that the oncogenic HPV caused cervical cancer and found this heterogeneous family and was able to describe. And within a space of 2 decades, it led to the development of a lot of HPV tests as well as the prophylactic HPV vaccines. So indeed, a very, very rapid development. And again, this meta-analysis from Cusick found that whether it was CIN3+ or CIN2+, and purists will say that it has to be CIN3, which is the true precursor lesion, there was a better sensitivity. And if you looked at the combined, there was a remarkable difference from 55% to 98%. So HPV test was clearly the way to go. And looking at the positivity in the under 35 as well as the over 35-year age group, so under 35, the positivity rate was a little bit more, but when you reached the CIN2+, there was a significant positivity of around 95%. So as far back as 2005, the International Agency for Research on Cancer already recognized that there is sufficient evidence that testing for HPV infection as a primary screening modality can reduce cervical cancer incidence and mortality rates, while recognizing that the main drawback is the cost, and low-cost public domain HPV tests need to be developed. And indeed, there were calls for such a thing funded by the Gates, but so far we have not met with success in this matter. And as data accrued, it was seen that women who were negative on these tests at baseline, if cytology positive, there was about a 0.9% risk of developing CIN3% versus a 0.27% risk if they were HPV negative, and that if there was a combined, there was only a marginal difference. So a marginal difference there with a lot more costs to double testing led to the increase of the interval to 5 years, as well as to a notion of primary HPV testing in women over the age of 30 years. So what happens then to our dear friend Papa Nicolau, and is it now obsolete currency to be tossed away and replaced? Well, WHO has definitely come out with the guidelines for screening and treatment in the LMICs, in the low and middle income countries, and has clearly declared that countries that have not already established cytology programs should not start to do so now. And they have a clear decision-making flowchart for program managers, which indicates that only if your cytology program meets the quality indicators should you continue with cytology and even add the HPV test. But if not, the choices are either an HPV or VIA, emphasizing all the while that we must try to make it a single visit approach, because otherwise the women get lost to follow up. And it's not screening that saves lives, it is treating the screen-detected lesions that is important. So I just want to show you a few glimpses of India when we talk about screening, and maybe you have all seen such pictures and maybe you have not. And we still have a situation where we have a lot of problems with transportation. There are women who can spend a great part of their day just sourcing water for their families, and yet they have access to mobile technology, which is now being perceived as the way to go in terms of getting messages across and bringing them in. And the urban, so you have the modern woman, you have modern healthcare and everything, but you have a lot of people. If India had 80% of people in the villages a decade ago, today it is 70%. 10% have moved to a few cities, and some of them live lives that are actually even worse than their lives in the villages were. So we have to deal with all these realities as we look at the various systems of healthcare. You have urban healthcare, which is so good. Medical tourism is a part of our lives now. You have rural healthcare, which technically provides a way to get to the apex institutions, but it doesn't necessarily always work. And so you have this situation of inadequate access, and you have a situation of lack of awareness. And as it turns out, India has very poor effective coverage, and only about 5% of women have ever been covered, some crude coverage beyond that, and the majority of women who have never had a pelvic scan, and scores over only very few countries in the world in this respect. Now, this was an effort to produce what was called a cancer atlas, which would go beyond the population-based cancer registries. We have about 27 of them, so almost on an average, one per state of India, but it doesn't necessarily capture it all. So they started a system of getting in data from other places and found there was a huge diversity. And this is where New Delhi is, where I come from, and our rate's about 15, but there is a vast variation in the kind of rates that you have across the country. So it was recognized for a long time that we have all these problems, the 3 M's as we call them, the men, money, and materials, so that a very preventable cancer is not yet prevented. And all the while, the Indian government has recognized, the Indian Council of Medical Research and the government itself, that we cannot consider putting in a cytology program. And this was even before we knew about how HPV is much better and all of that. So the plan was to look for alternate strategies that are feasible and scientifically valid. And here comes in VIA, VILI, and the question of affordable HPV testing, of course. So how many of you here have heard about VIA and VILI? Do you know about that? Well, some yes. So I will just talk about the visual screening. It's visual inspection with acetic acid and visual inspection with Lugol's iodine, and simple tests that allow the application of acetic acid and Lugol's. And large studies done in the south of India by the IARC group led by Dr. Shankar Narayanan found that it could, in fact, impact incidence and mortality. And then more recently, there was a presentation by Surendra Shastri at ASCO, which got him a standing ovation, where he said, because 5% acetic acid is vinegar. So he had this one. This one was in the rural area. This was in the urban area, and this was part of an NIH R01 grant, which showed that repeated rounds of VIA testing, even in the slums of Mumbai, were found to impact the mortality. So what we have now is that the VIA and HPV is better than cytology. Of course, VILI is kind of fallen along the line because it's expensive to get the iodine, and it requires a supply chain, which is difficult. The acetic acid can be reconstituted very easily by the nurses and the health workers. And as I mentioned, we've not had luck with affordable HPV testing. So this is an example of the naked eye inspection that is required. It's very important to have a good quality light. You dab the cervix, wait for 1 minute, and hey presto, you find that a lesion appears. And then come the nuances. There may be a very fine, white, not patchy, dotty, blotty kind of lesion, which is not significant. Conversely, it's a very clear white. You can see the geographical margins, it lasts for a bit longer, it's likely to be high grade. So all these things lead to a very high false positive rate, of course, but then the sensitivity is comparable with the pap smear. So the advantages are that it's inexpensive, it's simple, it's no lab support needed. You get the test result there and then, so you can do a screen and treat. A large number of women can be screened, and all levels of healthcare providers can be trained to provide this. And they have been shown by our studies to be as good as the doctors in this matter. But because it is subjective, you need good training and quality control. Of course, IARC has developed some manuals and some sort of criteria to try and objectivize it. And because there's low specificity, if you're not in a very high burden area, you might want to consider triage. Having said that, if you're doing cryotherapy, it's not really got too many side effects, but it's no good in the postmenopausal women when the squamocolumnar junction recedes into the canal. So the government of India then came out with this operational framework in 2016 at the behest of our Prime Minister, who said we must do something about the common cancer. So this one deals with cervix, breast, and oral cancer, which are our three most common and which are amenable to prevention, and lays down the complete guidelines on how these women are to be managed. And the attempt is really to go with a single visit approach, and there are clear guidelines for the ones which can get treatment with cryo. So the state of Tamil Nadu in the south had already started this initiative with NCD nurses who do the blood pressure, the urine for sugar, as well as, or spot test for the blood sugar, as well as the breast and the cervix examination. So since they were not doing a screen and treat, it was being seen that there was a lot of drop and loss to follow up, with consequent lower diagnosis of disease. So it was decided to go with the screen and treat model. And now all the states have started rolling this out, starting with a few districts which they will scale up. And so hopefully that will be good. And the other new advent on the market now is the thermal coagulation, where you can use the thermo sounds to heat them and destroy the lesions. So it's kind of a coming back of the electrocoagulation that there was. It's simple, it's fast, and the good news is that it does not require the carbon dioxide supply chain, which is a real problem with the previous method. But having said that, the equipment presently is expensive, so there's an attempt again to find a way to cut costs. So can we do HPV screening in the country? The question still remained, and there was this landmark study which was done, again, by the IARC group on a large number of women, 130,000 women, and they found that indeed the HPV was the best one as compared to cytology, VIA, and just an awareness drive, and the difference increased as the years passed by. They followed them for 8 years, and they found that this indeed was a good way to go, except that the VIA was the only pragmatic one at the present time. The other advantage with the HPV is that it lends itself to self-sampling. We used this chart which was developed by Niharika Khanna at Baltimore, and we translated it into Hindi. The health worker explained it to the women, and we found it was well acceptable with a good concordance. Some women do require supervision and help, but then nevertheless, even if the health worker helps, it removes the need for speculums and sterilization and light source, etc. So finally, we came out now with these guidelines for the screening and management. The ASCO has come out with a 4-resource kind of thing, maximal, enhanced, limited, and basic, but we found that was getting a little complicated, so we made it into 2, the high resource and the low resource. And we help to guide people through this to say you must do something. No matter what you do, do something. So if you can do HPV testing, then that's the greatest news. Go ahead, use all the techniques, genotyping, cytology, or even a VI. If you can't, just do the VI. And again, like the WHO says, if your cytology is good, carry on with that and do a screen and treat. So now I come to the role of the primary prevention, which is really one of the most exciting things. You all know about how the vaccine is a very safe prophylactic one with empty virus-like particles, high titer neutralizing antibodies, safe and effective, and the strength of association is remarkable. If smoking and lung cancer is 10, HCV and liver cancer 20, hepatitis B and liver cancer 50, HPV DNA of any type is 100, and HPV 16 is more than 500. There should be absolutely nobody who has any doubts that we need to prevent this infection. And we all know that screening does not detect all cancers, so even when we look at the map, we see that the highest uptake of vaccination has been in the countries which have the best screening as well. In India, for sure, with the inadequate facilities for screening, and we know there's poor compliance and facilities for management of these precancerous lesions, we have a great availability of infrastructure through the expanded program for immunization, and the best thing is there's good acceptance of vaccination by the people. Today, the woman who comes into the labor room with eclampsia, who never got her BP checked in pregnancy, did go somewhere and get her tetanus toxoid shots. So it is something where vaccination is trusted and accepted. And while we've talked about why we have 16, 18 with the overall 70, we have an 84%, and that's good too. Now, we did this very interesting study, which I would like to talk about, which was based on the finding from the Costa Rica dropouts that there was an efficacy even to the ones who had less than 3 doses for whichever reason. And based on this, the IARC started the randomized trial of 2 versus 3 doses in India at 9 study sites around the country. It was expected that this would not just give information on the efficacy of the 2-dose and 3-dose, and actually there's been no efficacy study so far. We've only done an immunobridging study which went towards licensure. It would also tell us about feasibility, safety, and acceptability, and would be useful for policymakers. So it was a fairly ambitious study of 20,000 girls planned. 10,000 would get 3 doses at 6 months. It was the quadrivalent vaccine because they were the first to come up with the donation. And so it was 0, 2, and 6, and 2 doses at 6 months apart, 0 and 6, and the plan was to follow them for 20 plus years. Though I have to tell you that when we went to the Indian Council of Medical Research, they said, we got back a comment saying that, do the investigators think they are immortal? So we said, well, there will be other generations to take it forward. So we had all these intermediate endpoints and et cetera that we were going to look at, the type-specific immunogenicity, the geometrical mean titers, the incident and persistent infections, and so on. And I have to say that by now, actually, the IARC has said that with the kind of information we have, even persistent infection is a good enough surrogate for vaccination. Previously, it was the development of CIN2, CIN3. Now they are even happy to accept persistent as a surrogate because we know exactly how the system works. Now, what happened was a very interesting situation for us, which was that due to problems with another trial, there was a ban, so you may say all HPV trials required to stop recruitment by the government. I don't know how many of you heard about this, but there was a fair outcry about it in the medical media, as it were, because there was absolutely nothing wrong with the trial that had been done. It wasn't really a trial. It was a demonstration project by PATH. The goal was to see whether it would be feasible to do it in a school-based or a campaign-based approach, and they took 2 states. They did 10,000 girls each, and about 5 girls died due to unrelated reasons: snake bite, poisoning, drowning in a well, malaria, cerebral malaria, viral fever, etc. And remote, more than a month away from vaccination. But a political storm ensued, and they blamed the vaccine, and they accused people of interest in the companies, and there was a lot of problem. They had finished vaccination. They just had the second round to go to, and they were planning to screen the moms, and they stopped all that. But for us, we were in the middle of vaccination when we were told to stop. So now a randomized control trial got converted into an observational trial, and very serendipitously, we had almost equal numbers in the groups. So I actually told the Indian Council of Medical Research that these girls who were in a very ethical trial have now been converted to guinea pigs. Because if I went and asked for permission to do a one dose, it would never have been given at that point. But because of the data that came out of this one, now we actually have one dose trials going on in the world. So I think it was eventually something good that happened. So anyway, so we had these groups, the day one, the 0 and 2 months who never got their third dose, the 0 and 2 months as planned, the 0, 2, and 3 months as planned, 0, 2, and 6 months as planned. And what did we find? What we found was the 16 and 18, both of them, the 2 dose and the 3 dose per protocol, were completely superimposed on each other for all the levels of antibodies. And the 0 and 2 months were actually at 1/10 of the level because these are log curves. So the 0 and 2 months were actually at 1/10 of the level. And even the 1 dose had some level, so it wasn't nothing. So it became very clear that you must have the gap, and now the recommendation is not less than 5 months. 1 month is this thing given. Furthermore, we are following them up. We're still following them up for the frequency of incident and 16 and 18 infection. We subsequently recruited a cohort of unvaccinated women as well, and we found that there is actually reasonable protection in all the groups, even the 2 dose at 2 months apart, even though they had 1/10 of the titer, and even in the 1 dose. And there is a substantially higher number in the unvaccinated women for 16 and 18 incident infection. For persistent infection, we find none of the girls so far have shown the persistent infection for 16 and 18. But if we look at the non-vaccine types, we see that the vaccinated and the unvaccinated have almost the same rates of incident infection, and we have persistent infection in a very small group. So it is exactly what we expect it to be. The HPV vaccination in India now, finally we're getting over the hump on the political aspects. Health is a state subject, so some states have introduced it. In Punjab, in the Delhi National Capital Region, in Punjab, they did a very systematic one in 2 districts, and they had an excellent coverage, 97%, with excellent safety and acceptability profile, and a small effort from a 3rd state of UP. And these guys in Punjab went through UNICEF, through the Gavi mechanisms, and sourced it at the Gavi price, which is less than $5. So it was in Indian rupees, 323, and additional operating costs of 100 rupees, and it has done a good job. The good news is that we now have an Indian vaccine coming up. The phase 1 has been successfully completed, and the phase 2, 3 trials are going to be supported by the Bill and Melinda Gates Foundation, the Department of Biotechnology, and the International Agency for Research on Cancer. So in conclusion, we can look at what does WHO say, and we're pretty much following that. Primary prevention, HPV vaccination to be targeted to 9 to 13, and starting with the girls for sure, boys when possible only, and give them a lot of awareness information. Male circumcision, I'm not touching on that, but this is a touchy topic in India. You cannot expect anybody to do it universally. Secondary prevention, targeting on the screen and treat, and then tertiary, of course, for when they are diagnosed. So Mahmoud Fatala, who was the president of FIGO, said, "Women are not dying because of disease we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving." So I'd like to acknowledge the group that works with us out in the field, the ladies who trust us and come to us for their screening, and all of you for your very patient hearing. And if there are any questions, of course, I'm happy to answer them. Thank you.
Do we have any questions for Dr. Chatla?
Thanks for your talk. I'm curious about the decision, and maybe it's a cost decision, of vaccinating only girls and not vaccinating both boys and girls equally.
So, there's been a lot of modeling studies that have been done on this, and they say, and there's also evidence now coming from Australia, most substantially, being the first country that really started the whole thing. So Australia, when they started it, and they started it on a very quick note because the Prime Minister's wife really supported it and came out and said that I had cervical cancer. She'd been to Singapore for treatment and nobody knew why she'd gone. And then when this whole thing happened, she was so brave and so kind. She came out and supported and said, I have cervical cancer and no girl should have it. Moreover, Ian Fraser, who discovered the vaccine, was from Australia and Man of the Year, and also it led to a very fast forward. So they started with the girls in the 13-14 age group. And at that time, we didn't really know this, but later we got data to see that if you do it in that age group, the titers are about twice or thrice as high as they are in the later years. And they did what they called the catch-up, and any woman up to 26 could go to a health facility and get it from her GP as well. And then very quickly, they found observational data, which was coming from their sexual health clinics, which showed a decline in the genital warts, which was the first surrogate. So the genital warts started to decline amongst the girls who had been vaccinated, more than the resident ones, more than the non-resident, but some decline even in those, and decline in the heterosexual men, but not in the men who had sex with men. And they found that there was no change in the herpes simplex and other infections while there was a change in this. So all in all, there was fair evidence that this was working. When they saw this business about the no decline in the MSM population, they said the boys should be vaccinated as well. And Australia and New Zealand were the first to start vaccinating the boys as well. So now the question is, what are you vaccinating for? So if you're vaccinating for cervical cancer, then the girls are the ones who are at risk. We know there is good protection from the vaccine. We know there's good herd immunity being generated. So the modeling suggests that if you are going to cover more than 70% of the population, then it's good enough to vaccinate only the girls. If you're going to cover less than that, especially if it's not even going to be 50%, then for sure you should vaccinate both for getting good results. So that is where the question then comes, do you have the money to vaccinate them all? Then it's great. The men, as somebody once stood up in an IPB meeting and said, you must think about the men. Men are not just mosquitoes. So you must think about the men. They do have other cancers like the oropharyngeal and the anal, and so many are being attributed. But we must remember, number one, the numbers are lower there. Numbers of cancers in absolute terms are lower, and the attributable fraction for HPV is also lower. And then the good news is that actually the oropharyngeals, which are HPV positive, actually respond better than the HPV negative. So for various reasons, there's not so much thrust on vaccinating for that. That's more like a side benefit than the main agenda, especially for countries like India. So we're really looking first at getting that covered. Even that is a challenge with the numbers. So we suggest going in a cohort at a time, and they started with the class 6 girls, for example, so that you build up the cohorts and find the money to do it. And that's how it is. Yes, so we don't really have a formal system of health insurance that is public. So there is private health insurance, of course, and the women who are most disadvantaged, of course, don't have access to it. Notionally, they do have access to a free primary health care system. And even, for example, coming to our hospital, if anyone's below the poverty line, then they can just get a waiver on all their costs. And even if they don't, it's not a very expensive thing, but resources don't match the numbers. So they are forced to go out and get it done privately, and they do sell property and stuff. So healthcare is actually the biggest cause of rural debt in India. So to that extent, the Prime Minister recently announced that we're going to have an insurance scheme that's going to cover everybody, and it's a little bit, it's been called Modi Care, after Obamacare and our President Modi, so it's being called Modi Care, but it's really fairly ambitious in the sense that no one really knows yet how the depths of it will work. So in Punjab, which is the state which first started, they do have a system of some kind of a cancer relief fund, and the government pays up to 1.5, so 150,000 INR for cancer expenses, and the rest are out of pocket for the person. So they did a cost-effective modeling based on this, based on their expenses of 150,000 to each cancer patient versus the cost of giving the vaccine at this rate of INR 323 as they had got it with these costs. And they found it to be a more cost-effective method to go with.
One other question. In the see and treat kind of paradigm, is there ever a role for biopsy confirmation, or does that run into the same limitations of not having skilled staff to interpret that? And for the women that, it sounds like most women are diagnosed with invasive carcinoma, they just go right to hysterectomy.
Yes, so the see and treat can be done in two ways. In fact, we're calling it screen and treat when we do VI and treat it, because the see and treat concept actually came up from this part of the world where they used it in colposcopy clinics where women come with a pap smear report, which is positive. Now, pap smear we know has a low sensitivity, but it has a great specificity. So if your pap says you're abnormal, you're most likely abnormal. So if they come with a pap smear abnormal to the colp clinic and they find a high-grade lesion on colp, then they said, let's just go ahead and do the leap straight away, because I guess the same problem of getting the woman in again applies to all. So that is where the see and treat started. So we call it screen and treat to differentiate it a little bit, because if we're doing it on a VI, we know we don't have that grade of specificity, and a VI positive may really not have significant disease. So having said that, there's two ways to do it. If you're sitting out in Africa where there are no pathologists, you just do it and hope that it'll be good. And if you're doing it in India, then you can actually take a biopsy and freeze it at the same time. So you will get a post hoc confirmation, and you will know whether you undertreated or overtreated or adequately treated, whatever the case may be. So if it's overtreatment, as I said, if the fertility is complete and it's only a cryo or thermal ablation, we don't really have too much worries. In HIV-positive areas, there is a worry because it increases shedding. And we do advise that they should have abstinence for a month after the procedure while the cervix heals. And that kind of thing causes a lot of grief in places like Africa, where it can lead to domestic violence, and women are routinely seen with teeth knocked out from domestic violence. But in India, there's a lot of philosophy of periods of abstinence during the religious periods. And also, I think we've never really encountered anybody with that problem of advised abstinence. So basically, you do that, you get a post-hoc confirmation, and you see how it goes. So no, it's not true that we would find them all with invasive, because wherever we have run screening programs, we have found a lot of women with pre-invasive disease, and we have done our studies on screen and treat and all based on all of those women we find then. So I think once we get into a program, we will definitely find a lot of women who will be there positive. Thank you so much. Thank you so much. Thank you for coming.